two questions in the chat. One was how quickly do we get our results back, and we get them back the same day. Second question, how do I adjust for the trough? The trough is really dose again, and it's a question of can you get your trough into the therapeutic range without your peak going beyond the therapeutic range? And if you cannot achieve that, then you have to go to a 3 times a day regimen. There's a quick answer. I didn't see any other questions. So the MHVIP study, which I wanted to call Improve, but then the people in the clinical trials unit said, look, there's been hundreds of studies called Improve. You have to find something that's a bit more unique. So hence we said, well, okay, the MHVIP study. So if anybody's got a better name, very happy to consider it. So we all know the problems that we face when we are looking after people with a mechanical heart valve, and they are, on the one hand, thrombosis, and the other hand, bleeding, which means it's a sort of twin-edged sword, which you can't almost get right. If we go back to the lovely ROPAC study that we talked about before, the problems in the first trimester, and I've highlighted first trimester here, valve thrombosis occurring with VKA in blue and low molecular heparin in red. And you can see the rates compared to later in pregnancy, second and third, are relatively low. Other thromboembolic events, again, relatively low, but still occurring. But hemorrhage is very low. And again, these are only in the heparin group, not in the VKA group, which comes back to my theory that if we're seeing valve thrombosis and we're not seeing bleeding, then are we actually giving the right amount of anticoagulation? If we look at the rates, that's why I'm talking now, where I'm meant to go on to the next one. Second and third trimester, again, valve thrombosis rates are relatively low in the VKA, but higher in the low molecular weight heparin, implying that we're not effectively anticoagulating. If you look at bleeding, we're seeing higher rates with the VKA and relatively lower rates with the low molecular weight heparin in the second and third trimesters. So again, here we're saying, are we actually effectively anticoagulating? Because we would expect to see almost equivalent rates if we had an equivalent anticoagulation, if you see what I mean, in terms of protection from valve thrombosis, then I would have expected to have seen a similar rate of hemorrhage. So what I'm saying here really is we are not effectively anticoagulating when we use low molecular weight heparin. So what's going on in India at the moment? Well, the wonderful MPAC registry in the 65 women with a mechanical heart valve, there was an 8.6% maternal death rate, 17% of valve thrombosis, and 33.7% adverse fetal outcome rate. In a second paper, 138 pregnancies really comparing continuous VKA versus sequential, showing that sequential was actually much worse than continuing with the VKA in terms of maternal death, 0 versus 5.7%, thromboembolic events, 6.3 versus 14.2%, and adverse fetal outcomes, 18 versus 34%. Really, I'm resting my case that the sequential regimen does not do what we want it to achieve. So this was our paper, Tosanta's paper 2020, when we reported on 14 women who we managed on low molecular weight heparin throughout pregnancy in one center. We had no deaths, no valve thrombosis, and 100% live birth rate, although we had 2 deaths related to prematurity. We now have 22 women, 1 stillbirth, but still no valve thrombosis or thromboembolic disease, and that will be reported soon. The Remtula paper, 48 women with a mechanical heart valve on low molecular weight heparin from 11+3, as I mentioned, in one center in Johannesburg, 5 women on VKA. There was no maternal deaths. There were 2 valve thromboses, 1 on low molecular weight heparin and 1 on VKA. 56% live birth with low molecular weight heparin, only 20% with VKA, and reasonably high rates in the low molecular weight heparin group of antepartum postpartum hemorrhage. And understanding how that antepartum postpartum hemorrhage distributes is key to working out how we should manage the transitions from one regimen to another. But the message from this slide is, look, low molecular weight heparin can be as effective as VKA in terms of prevention of valve thrombosis and prevention of thromboembolic disease. So what are we doing to reduce mechanical valve thrombosis in our study? Well, we're going to use a high initiation dose, as I mentioned, 1.35. We'll be testing after the third dose to make sure we've achieved a therapeutic target. And then we'll be testing weekly until we have a stable level. And we'll be doing repeat weekly measurements if we change the dose. Once we're stable, we'll go to 2 weekly measurements. We will be using peak and trough, and we will be willing to convert from a BD to a 3 times a day dosing regimen if it's necessary. We'll pay particularly close attention to the transition from agent to agent, and we have clear instructions of how to transit from one to the other. In terms of hemorrhage, largely it's going to be the same thing. We're going to be testing after the third dose to make sure that we don't have too much anti-factor 10A levels, too much anticoagulation. We'll be testing weekly until it's stable, and we'll be testing weekly if we change the dose, and thereafter 2 weekly and peak and trough again. Before we deliver, we'll want an anti-factor 10A of less than 0.3, particularly for cesarean, but also for vaginal birth. And we'll be delaying our transition from low molecular weight heparin to VKA until day 15 post-delivery. So our hypothesis is that optimally controlled low molecular weight heparin throughout pregnancy is non-inferior to the current standard of care, which either can be VKA throughout or a sequential regimen. In terms of risk of valve thrombosis, maternal death, and second part of it, 2 primary outcomes, is that a low molecular weight heparin regimen would be superior in terms of fetal loss. So we're going to do a randomized controlled trial of low molecular weight heparin compared to a VKA-based regimen, either continuous or sequential. And we're looking at a non-inferiority in terms of valve thrombosis, maternal death, and a superiority in terms of live birth rate. This is what we're actually going to be doing in the study. We want to randomize before 8 weeks, and as I said, really as early as possible, because we want to reduce the rates of embryopathy and therefore of early miscarriage. When we convert to low molecular heparin, as I mentioned, it'll be at a higher dose and with close monitoring. When we convert in the other side of it to low molecular weight heparin at 36 weeks, again, it's going to be at the higher dose and with close monitoring. And similarly for delivery, if it's low risk, we'll continue with the low molecular heparin, stopping just before we want to induce or are going to deliver. And then if it's high risk, we'll go to unfractionated heparin. We will delay till 14 days or just before 15 days to switch back to VKA. And we're really keen to understand what is the impact of VKA on the fetal brain. So we will be doing an MRI scan less than 12 weeks post-delivery. We'll review finally at 6 weeks, and that's when the study will close. And again, another summary of what we're going to do, which I won't go through. So our power calculations, that we estimate we'll need a sample size of 297 in each group, which will give us a 90% power with a p-value of 0.025. It will give us a non-inferiority difference of 0.1, assume 1%, assuming that a rate of valve thrombosis of 0.17% in the control group, and accounting for a 10% dropout. And similarly for superiority, we'll only need 232 per group, so we'll be able to do that with the same numbers as we used for the non-inferiority. How do we see our study impacting clinical practice? Well, it will define the optimal anticoagulation regimen for mothers during pregnancy. It will tell us about pregnancy loss. It will tell us about rates of embryopathy and fetopathy using either regimen. Most importantly, it will improve preconception counseling for women with mechanical heart valve and actually inform women before they make a decision about which sort of valve to replace their diseased valve with. If we can prove that low molecular weight heparin is as safe as VKA and better for your baby, then it will be safe to have a mechanical heart valve, which, as we know, has a much longer lifespan than a bioprosthetic valve. Currently in the UK, 60% of women of reproductive age are opting to have a bioprosthetic valve, which obviously has implications for longevity of the valve, need for reoperation. Yes, the valve-in-valve replacement, the TAVIs and so on are changing that, but I don't know that we have enough data yet to be secure in recommending a bioprosthetic valve as being the safest option. And of course, once we've set up this study, it will enable us to do future studies, like, for example, the addition of aspirin to low molecular weight heparin if we are not able to achieve as good protection using low molecular weight heparin alone. Thank you for your attention. I'm very happy to answer any questions. Oops, let me just stop sharing.
So thank you, Professor Mark. It was a clear presentation of what is the hypothesis and how you are proceeding with. Now, dear investigators, the floor is open to you. This meeting is primarily for you. You can switch on your video, or if you can choose to stay off, it is fine. Please ask your questions. The questions can be on, the hypothesis or your concerns about the safety or efficiency or the logistic feasibility at your center. Any question is fine. So please feel free to ask your questions. We are looking forward for active participation, and a center which will be able to enroll 10 patients in a year, that will be very wonderful. We need some 10-15 centers like that. That will do the justice.
So, Dr. Mark, I just wanted to ask you, it's a standard practice patients who are on VKs will be on aspirin as well. So the second arm that we use without the low molecular weight heparin, will we be justified in withholding aspirin to that group?
I mean, there's the standard of care
Especially the
arms.
mitral valve patients.
I'm sorry, I missed the second part there.
I said especially the mitral valve replaced
Yeah.
patients.
So the standard of care arm, in it, you can use what you as your clinician judgment would like to use. It's only in the low molecular weight heparin arm that we would only want to use low molecular weight heparin.
Can I just say, if somebody has a high risk of preeclampsia, would you let them continue the aspirin for preeclampsia prophylaxis, or would you?
Yes, we would.
So I think in answer to the question, you could use aspirin if it is justified for the pregnancy, or if the woman has been on aspirin pre-pregnancy.
But not in the low molecular weight arm, because we know that 60% of people bleed if you're taking aspirin and low molecular weight heparin. But if you're taking aspirin for preeclampsia prophylaxis, we know that the coexistence of preeclampsia and heart disease is really very bad news in terms of maternal mortality. So in my mind, I'm happy to use the aspirin to prevent preeclampsia, but not as an adjunct in terms of low molecular heparin.
Will that constitute an exclusion criteria now that we know aspirin plus low molecular heparin, the bleeding rates are going to be high?
So we will be, for protection or reduction risk of preeclampsia, we will continue it to 36 weeks. And so no, I don't think we would do that. I'd say we should continue taking the aspirin, but because by the time of delivery, which is the time we're going to worry about primarily, we should be off the aspirin.
You had 48 patients in your study. How many of them were on aspirin?
In the Remtula paper, the 48 people, none of them were on aspirin that I remember. I have to go back and check for you. I'll come back to you if I may. Good question. What are the exclusion criteria? I can pull those up, but I mean, they're the usual
And
things.
that is by Professor Sarita. She is the OGPI of AIMS Raipur.
Thank you. Thank you for the question. It's a very good question. So if they can't consent, you can't make people understand what you're actually trying to do, would be an exclusion. If they are more than 8 weeks, would be an exclusion. If they have multiple pregnancy, an exclusion. Yeah. If it's not available in your city, we will establish it in the hospital. And obviously, part of the study would be paying for the anti-factor 10A analysis as well. So we would pay for its establishment.
Dr. Dinesh has asked a question. from Sardar Patel Medical College. Dr. Mark, I think you can address that.
I didn't see that one. Was that the one about the establishment of the?
If anti-TNA is not available in our city.
Oh yes, then we would establish that. Yes.
Dr. Mark, thank you very much for your wonderful talk. How about centers where we already have anti-TNA assays, but we're unable to run it when we adjust the dose, we can't do it on a 3-day basis, but possibly considering 1 week because of the reagent?
That would be our job to make sure you had the reagents. So we would be trying very hard to make sure you had the reagents so that you could do the study as per protocol. Yeah, DMC R&D are going to be in charge of that. So you'd be on the phone to DMC R&D and say, where are our reagents? But no, we would make sure you had enough reagent.
Okay, thank you.
That's a pleasure.
I think it would be safe to say you could do it in 72 hours as well if you don't have the reagents, because in practice, would 2 or 3 days make a difference?
I mean, you could, but that's not ideal. I mean, what we're trying to do is optimize the management regimen. And it's really a question of supply, isn't it? So we would have enough supplies of the reagents to make sure that the assays could be run. That would be our job.
There is another question from Malaysia.
Yes. So if you stop therapeutic low molecular weight heparin, we usually give 24 hours. What I would do though is also measure the anti-factor 10A level, and 0.3 is the level at which I would not be happy to do a spinal. And why do I say that? 0.3 is the sort of peak you might expect from a prophylactic dose of low molecular weight heparin. So if anything's less than that, then I think it's safe surgically. If you have a level of less than 0.2, it's deemed to be safe. And some of the risks of hemorrhage may be because your antifactor 10A level is actually persisting too high. But no, we here have used 0.3 and the anaesthetists have said, okay, 0.3 is fine. We're happy to put a spinal in with 0.3.
Any centers other than India you're looking at in Malaysia? Is it being considered?
I hadn't thought about Malaysia. Do they have a lot of mechanical heart valve there?
MJ?
We have quite a few actually. We work with Dr. Geeta in the National Heart Center. So we have about 14 patients in the last year, I think, that we've done.
Perfect.
And we already have 2 ongoing at this current time.
Mhm.
One is in about second trimester, another one in the first trimester.
Well, if you're interested in taking part, please do send me email and I'll send a protocol and yeah, that'd be fantastic.
Okay.
Thank you. Do you have my email, by the way? Is it on the?
I think, yeah.
Any questions? Other potential sites? Anybody from Fernandez? Dr. Malini, are you there? Meanwhile, I'm sharing. Dr. Marcus Joy. I just shared this. Okay, you had already shared your email. That's fine.
Thank you.
Right.
Good evening, Dr. Justin, Dr. Malini here.
Yeah, good evening, Dr. Malini. Thanks for joining. You have any comments or any questions?
My only concern is that we are a private organization. We may not have such numbers that you're talking about. So how do we plan to randomize into the LMWH or the VKA group when the numbers are very less?
Okay.
How many do you have per year?
Maybe 3 to 4 a year.
Okay.
Or sometimes less.
Are you close to any other centers?
I think we are the only one in Hyderabad that joined this meeting today, but the Chennai and even the Pondicherry, the Jipmar is a little closer to us.
So I would, Dr. Paul, you're going to have to answer this one. I think if we can work with you from another site, that would be brilliant.
I think we'll connect Professor Mark, Dr. Marley, and me, and then we'll take a call
Perfect.
on this.
Thank you.
Thank you, sir.
Anybody else who has any questions? Any other centers? Rupali, SGPGI, any comments, anything?
No, sir. I think it's a good question to be, get answers from the study, because having this levels tested is always a big challenge, because most of the studies have shown. So I think, and none from the India. We don't have any centers from India studies. So I think that will be a good opportunity to see how this low molecular heparin, especially in Indian population, work. So looking forward to it.
Thank you.
Dr. Rupali is from SGPGI Lucknow. They are our very active partners of the NPAC India study. And we have, Dr. Mark, we have crossed 6,000 enrollments as of today.
Well done.
Thanks to, most of the investigators here are active enrollers here, starting from Professor Vander. Everyone is actively enrolling. Any other comments?
Yeah. So there's a question about compliance. Dr. Sarita is asking
Yes.
about plasma monitoring. So it's a good question. So when we are doing a Vanguard phase, which is recruiting the first 100 patients and looking at exactly that question, how good are people's compliance, or do they turn up when we ask them to turn up? Do they take their injections? And obviously, do they take their VKA? In our hands, we find that people do. They do it because, one, they're really concerned about their child, and they're two, because they're concerned about their own health. But we have good compliance. There are people who are less good. In the paper that we were talking about in Johannesburg, the good compliance was about 90%. So you're absolutely right that we will find some people who are not compliant. But yeah, that's what we're trying to find out. So we may have to increase the numbers to take into account those people who do not do as we ask them to do.
Dr. Annie, any questions? You had something?
Good evening, sir.
Yeah,
So this during during delivery and labor, will the low molecular weight heparin be continued or switched over to unfractionated heparin, sir?
Depends on the level of risk. So if you're low risk, then I would just omit the low molecular weight heparin. If you're moderate to high risk, then I would have you on unfractionated heparin.
Now, after delivery, when do you restart heparin?
Yeah, good question. So I would normally give the prophylactic dose. So if 40 milligrams that night, for example, depending on the weight, and then start therapeutic the next morning. So within 24 hours, I'd have people back on effective anticoagulation.
Maybe fair to say 6 hours after they give birth, whatever time of the day.
But that's, yeah, if they're having regional anesthesia, more than 6 hours, because they're going to, if they're taking the epidural catheter out, but 6 hours for the prophylactic, and then back to therapeutic the next day.
Anyone else?
I guess the key question is everybody happy to take part in the study? Is there anybody who's worried about taking part in the study? So there's another question. Would we be providing the low molecular heparin? The answer is yes.
All the potential participating sites low molecular weight heparin will be provided, and
Yes.
anti-10A monitoring feasibility will be provided. And if
Yes.
you have the center, the patients, the costs will be covered. Insurance will be provided.
Yep.
And I think for centers that are recruiting more than 10 patients a year, we will have a clinical research fellow as well.
Yeah.
Yeah.
A good point. Thank you, colleague.
Yeah, I think you'll have somebody working in your working with you to help you enroll, update, as long as you'll be able to enroll more than 10 patients a year. That's a good point, Guling.
Yeah.
Good thing you
Yeah.
have to us.
So we've got the Imperial Clinical Trials Unit team who will help us with the randomization and recruitment as well. So they'll be overseeing the study, and then there'll be a clinical research fellow at the site. So I think because it involves a lot of data entry.
Dr. Shakun, any comments? What is your opinion? Dr. Shakun Tyagi is from GB Pant Hospital, Maulana Azad Medical College, New Delhi. She is a very active member of NPAC India study and active role in protocol development.
Wonderful.
Good evening, sir. And
Good evening.
it's good this study is being carried out, but it should have been our take. The number of metallic valve replacements we deal in India is enormous. So, but still it's coming on, and it's high time it's there. I just had one reservation because we are going to randomize, and more and more patients in our hospital and otherwise also, they are more worried about the babies now. And when we give them an option of both, whether they want low molecular weight heparin or vitamin K antagonist, they are opting for low molecular weight heparin. So in that case, those women will not be able to randomize them, and they'll be like, they can fall in either of the group, and we'll have to exclude them for the study.
Yes.
So that was my one concern. Like now people are becoming more and more knowledgeable. And once they know it can harm the baby, even if it's costly, they opt for low molecular weight heparin. So that is my only concern. We do get about 10 to 12 women of metallic valve replacement per year, but that's a concern.
What proportion of them opt to have low molecular weight heparin throughout the pregnancy?
Yeah. So once they opt for it, we can't randomize. We can't put them in like randomization.
Of your 10 to 12 women who come through each year, what percentage of them, or how many of them, choose or opt to have low molecular weight heparin throughout?
Almost 50%. Almost 50%.
Okay.
Oh,
so that the randomization.
So Mark, are you looking at a parallel registry for
I was also going to say the same actually. Why eliminate them out of the study? Intention to treat.
Exactly. So people who refuse to take part, we will recruit as well to see what the outcomes are. Absolutely right. Thank you.
So, we are already having that NPAC registry now. We had 12 patients last year, and before that also 6 patients.
This will be starting after our
Yeah, I understand. Yeah. Okay, thank you. Thank you so much.
Thank you very much.
Any other concerns, any other sites? So Samina from Jaipur has joined now. Not sure if so Zamina, you would like to ask anything? Dr. Asha Verma is also there from SMS Jaipur. Sir, you have anything you want to ask?
No, nothing specific.
Okay.
Good evening. Thanks. Sorry for joining late. Thanks.
He's a PI from SMS Medical College Jaipur.
Thank you.
So, shall we close then? Dr. Mark, what would you like to say now?
Nothing except to say thank you very much indeed for your time. Thank you for arranging this wonderful event for me. It's exceptionally kind of you. Thank you. And thank you for all the people who've attended for listening and the really, really good questions. And I hope you all would like to take part in the study.
Annie, I think you can say the word of thanks. Annie, are you there?
Yes, sir. Yes, sir. So it is indeed a great pleasure to hear our esteemed speaker, Mark Johnson, sir. So we had a lot of insights, and regarding the study also, a lot of queries being addressed. Thank you so much, sir. And I thank each and everyone who had participated in this, and I'm sure that we would move forward into a new path. So thank you so much for all of you for staying back. Thank you. I especially thank Justin Paul, sir, for introducing us into this newer thing. So we pray that by God's grace, we would all progress into this study. Thank you so much. Thank you all for joining.
Thank you.
Thank you all. Thank you all for staying back. And the lecture and the discussion will be uploading in the YouTube channel Cardio-Obstetrics. We'll be sharing very soon. Thank you so much. Thank you. So good night, all of you. Thank you for your time.
Thank you.
Thank you.
Good night.
Thanks.